Welcome to Hand Surgery Resources Podcast. Welcome to Hand Surgery Resources Podcast on Carpal Tunnel Syndrome. This podcast highlights the major symptoms, signs, treatment options, and outcomes and key points related to carpal tunnel syndrome. Carpal tunnel syndrome is the most common compressive neuropathy in the upper extremity. The incidence of carpal tunnel syndrome in the United States is 50 cases per thousand per year, with an incidence range varying from 0.1% to 9.2%. The incidence of carpal tunnel syndrome is 2 to 3 times greater in females compared to males. The carpal tunnel is an anatomic structure located at the wrist and the base of the hand. It is formed by the carpal bones and the transverse carpal ligament. The result is an anatomic tube containing 9 flexor tendons and the median nerve. The ring of carpal bones and the transverse ligament cannot stretch, so swelling of the tenosynovium in the carpal tunnel can compress the median nerve. The median nerve provides sensation to the thumb, index, long, and ring fingers. It also provides motor innervation to the thenar muscles at the base of the thumb. The diameter of the carpal tunnel varies minimally from right to left and is notably smaller in females than in males. The most common symptoms are fingertip numbness in the radial 3.5 digits, specifically the thumb, index, long, and half the ring finger. And secondly, painful tingling, that is, paresthesias of these digits. Symptoms are often noted bilaterally. In addition, the patient may report that the symptoms are aggravated by repetitive use of the hand or wrist. Nighttime pain, tingling while driving, and dropping objects more than usual are also frequent complaints. In addition, patients often complain of waking up at night with severe tingling, which is only relieved by shaking their hands vigorously. Finally, patients sometimes complain of weakness. However, usually this is a lack of sensation rather than true thenar muscle weakness. An individual holds an object like a pen because they can see it and feel it. If the patient is distracted and there is decreased sensation in the hand holding the pen, the reflex to continue holding the object is disrupted. The patient then drops the object and interprets this as weakness, when in fact the thenar strength is intact and the problem was lack of sensation. A thorough past medical history is also important in patients with carpal tunnel syndrome. It is important to know if the patient has diabetes, cervical arthritis, cervical disc disease, a history of cervical injury, thyroid disease, or any other neurological disorder that might coexist with carpal tunnel syndrome, or is causing symptoms suggestive of carpal tunnel syndrome. The physical examination for carpal tunnel syndrome should include a sensory exam, a thenar muscle exam to check for thenar weakness or atrophy. Carpal tunnel symptoms and signs can come and go and are varied in intensity. The patient may report, "I only have tingling at night." Because of this variability, provocative tests like the median nerve compression test or Durkin sign, the Tunnell sign, the Phelan sign, and the Flick sign can be very useful. The sensory exam can be done with light touch, 2-point discrimination, vibration, etc. I prefer a light touch exam. The sensation exam should begin by establishing the patient's normal intact sensation. This can usually be done by examining the normal sensation in the fifth finger. Occasionally, light touch on the face of the patient gives the patient a clear understanding of their normal baseline light touch. Assuming the palmar little finger sensation is normal and perceived as normal by the patient, then the first sensory carpal tunnel exam should be done by comparing the sensation of the little finger to the sensation on the palmar tip of the long finger. The sensory deficit in carpal tunnel syndrome may not involve all the digits innervated by the median nerve. Typically, the first area to demonstrate decreased sensation is the tip of the long finger. Thenar muscle examination is done by having the patient place the hand in a palm-up position on the hand table. The patient then firmly pinches the thumb tip against the tips of the mildly flexed index and long fingers. With maximum effort, this maneuver should make the thenar muscles, which are ulnar to the thumb metacarpal, bulge out slightly and feel firm when palpated by the examiner. If there is a defect where the thenar muscles should be located, this is consistent with thenar atrophy. If the thenar muscles feel soft and mushy, this suggests partial atrophy and weakness. The strength can also be graded on a 0 to 5 scale. The strength is assessed by observing the force required to break the patient's pinch by pulling the examiner's index finger between the patient's thumb and index finger. The pinch can be further assessed with a pinch meter, which measures the strength of pinch in pounds or kilograms. Finally, strength can be evaluated with a grip testing tool. As noted, patients often present without symptoms. In this situation, provocative tests like the median nerve compression test or Durkin sign, the Tunnel sign, the Phelan sign, and the Flick sign that are all designed to cause tingling in an asymptomatic patient or relieve tingling in a symptomatic patient are very useful diagnostic tools. In the Durkin sign, the median nerve is compressed by the examiner's thumb at the proximal transverse ligament or just proximal to it. This causes decreased blood flow in the epineural vessels of the median nerve and produces a temporary relative ischemia. This ischemia initiates paresthesias in the patient with carpal tunnel syndrome. The pressure should be applied to a relaxed wrist for 45 to 60 seconds and produce tingling that is consistent with the patient's symptomatic complaint. For example, the symptoms should mimic their nighttime paresthesias. The Tunnel sign is another maneuver which can provoke the paresthesias of carpal tunnel syndrome. For this test, the wrist is placed in the palm-up position with the wrist dorsiflexed and relaxed. It may take some gentleness to put the wrist in this position without causing excessive pain. With the wrist position, the examiner taps the nerve firmly just proximal to the transverse carpal ligament. A positive Tunnel sign produces tingling, that is paresthesias, radiating distally into the digits innervated by the median nerve. The Phelan test provokes tingling by temporarily increasing the pressure in the carpal tunnel by placing the wrist in marked palmar flexion with the elbow straight. After 45 to 90 seconds in this position, the compression of the nerve will produce symptomatic tingling in the carpal tunnel patient, thereby demonstrating a positive Phelan's test. The Flick sign is not strictly a provocative test. The examiner asks the patient to demonstrate what they do at night to relieve their paresthesias. Carpal tunnel patients hold their arms up and shake their hands. This observation can also be made by having the patient shake their hands immediately after a positive Phelan's test to relieve their provoked paresthesias. Finally, an important part of the evaluation of a carpal tunnel patient is examining the patient to uncover coexisting problems that may also cause the patient's hand pain or in fact be the true cause of their hand complaints. The four most common diagnoses to check are signs of decurvain sinusitis, thumb CMC joint osteoarthritis, which is present in 50% of patients with carpal tunnel syndrome, trigger fingers, and trigger thumbs. Therefore, a thorough exam of this group of patients should include a Finkelstein sign for decurvains, a thumb CMC joint compression test to rule out thumb CMC joint basilar arthritis, and checking for triggering of any digit and for A1 pulley tenderness of the thumb through the little finger. The diagnosis of carpal tunnel syndrome can be confirmed by electrophysiological testing, including nerve conduction velocity testing, so-called NCV, and needle EMGs. For NCV studies, the function of the peripheral nerve is evaluated by electrically stimulating the nerve and recording the response at the muscle or the nerve. When compared with normative data, the response can yield useful information about nerve function, demyelination of the nerve, and axon loss in the nerve. NCV testing can be done for motor, sensory, and mixed nerves. For EMG studies, muscle function is evaluated by inserting a needle electrode into the muscle and recording the intrinsic electrical activity of the muscle fibers. In carpal tunnel syndrome, EMGs can assess the inner muscle function. Ultrasound measurements have also been used to confirm carpal tunnel syndrome by measuring the cross-sectional area of the median nerve at the level of the carpal tunnel. Carpal tunnel syndrome is the most common compressive neuropathy in the upper extremity, but it is important to consider the differential diagnosis and to be aware that carpal tunnel syndrome can coexist with other causes of hand pain and with other neurological disorders causing paresthesias in the distribution of the median nerve. Further, other nerve problems can cause symptoms that look like carpal tunnel syndrome. The double crush syndrome is the combined problem of carpal tunnel syndrome with cervical arthritis and/or diabetes. This syndrome proposes that mild cervical spine disease can cause a minor asymptomatic proximal compression, or diabetes can cause a slightly damaged but asymptomatic median nerve. In both situations, this mild compression can mean that an additional mild compression of the median nerve at the wrist leads to symptoms which otherwise would not occur if the two disorders were not present simultaneously. Finally, other neurologic disorders can cause hand numbness and weakness without any carpal tunnel syndrome. For example, C6 radiculopathy can cause numbness and painful paresthesias or tingling in the thumb and index finger. Treatment options for the carpal tunnel syndrome can be non-surgical or surgical. Non-surgical treatment options include nighttime splinting, medications such as non-steroidal anti-inflammatory drugs like naproxen, oral steroids, or cortisone injections into the carpal tunnel. These non-surgical options do control carpal tunnel symptoms in most patients, but are more likely to be temporary solutions. Surgical treatment focuses on surgical release of the transverse carpal ligament to enlarge the space which encloses the median nerve and flexor tendons. Surgical treatment options include open carpal tunnel release, mini open carpal tunnel release, or endoscopic carpal tunnel release. At 3 to 6 months after surgery, there is no statistical difference in the outcome from these three different surgical approaches. Endoscopic surgery has a slightly quicker recovery, but minimal improvement in the return to work times, with a theoretical small increase in the risk of nerve injury. Overall, there are no long-term differences between surgical options. In all surgical procedures, there is a small potential for complications like nerve injury, infection, persistent symptoms, continued thenar atrophy, pinch problems, etc. The need for repeat surgery has been reported to be under 5%. Overall, the outcomes from treating carpal tunnel syndrome are excellent in most patients with good patient satisfaction, improvement in patient symptoms, and improvement in their function. In conclusion, let us summarize the key points regarding carpal tunnel syndrome. These points include: 1. The carpal bones and the transverse carpal ligament are the components of the carpal tunnel. The bony attachments of the transverse carpal ligament are the ridge of the trapezium, the tuberosity of the scaphoid, the hook of the hamate, and the pisiform. 2. The most common cause of numbness and tingling in the upper extremity is carpal tunnel syndrome. 3. Carpal tunnel syndrome is more common in women and often associated with thumb, CMC joint, or basilar joint osteoarthritis, trigger fingers, or Decker-Vein's tenosynovitis. 4. Carpal tunnel compression testing, the Durkin sign, is the most sensitive and specific physical exam sign for diagnosing carpal tunnel syndrome. 5. Carpal tunnel syndrome can accurately be diagnosed by history and physical examination, but the diagnosis is often confirmed by EMG NCV testing. 6. Treatment options include non-surgical and surgical choices and are successful in most patients. 7. There remains a continued debate on the mandatory use of diagnostic EMG NCV testing, debate on the need for diabetic control for surgery, debate on open versus endoscopic surgery, and finally debate regarding the need for perioperative antibiotics for carpal tunnel syndrome, particularly in healthy patients. 8. Carpal tunnel syndrome is common in pregnant women in the third trimester of pregnancy. Fortunately, their symptoms can usually be controlled by splinting and other non-surgical options. Thank you for listening to our podcast on carpal tunnel syndrome. For more information regarding carpal tunnel syndrome and other diagnoses, please see our website, www.handsurgeryresource.org. At that location, you'll find our comprehensive online text hand surgery source, or find this at the Apple App Store or Google Play, where you will find the app Hand Surgery Source. Thank you for listening.